Good morning to all. First, I thank ASOS for this opportunity. My topic is Applied Anatomy of Lid. The functions of lid include protection of the eye, and it keeps the eye moist, and it has an important role in the facial features of an individual and give awareness about the state of wakefulness of an individual. First, we can discuss about the embryology of the eyelid and congenital anomalies. Embryologically, the upper eyelid develops from frontonasal process and lower lid from maxillary process. First, this eyelid folds appears in this upper eyelid fold appear in the frontonasal process and lower lid fold in the maxillary process by about 6th to 7th week of gestation. Incomplete development of this eyelid folds leads to ablepharon and microblepharon. Then this eyelid folds has to fuse by about 8th to 10th week of gestation. Then defective fusion leads to eyelid colobomas. Maybe either upper lid coloboma or lower lid coloboma or both lid having coloboma. Maybe associated with iris coloboma, lenticular coloboma, and chorioretinal colobomas. Then meibomic glands and eyelashes differentiate from a common pilosebaceous unit by about 2 months of gestation. Their defective differentiation leads to congenital distichiasis. It is characterized by an additional row of eyelashes, and these lashes are directed towards eyeball and cause irritation of the conjunctiva and recurrent erosion of the corneal epithelia. And the treatment for this include epilation. Then the eyelid structures develop by about 3 to 4 months of gestation, and their defective development leads to congenital ptosis. Congenital ptosis is characterized by absence of the upper lid crease. If the congenital ptosis is severe, that is, the lid covers the pupillary area, there is a chance of development of amblyopia. So, it is an indication for early treatment for congenital ptosis to prevent amblyopia. Then this fused eyelid has to be separated. This eyelid disjunction takes place by about 5 to 6 months of gestation. Its defect leads to ankyloblepharon, that is attachment between upper and lower lid, or blepharophimosis, that is narrow palpebral fissure. Then about the extent and position of the eyelid. The upper eyelid extends from the eyebrow to the upper border of palpebral fissure, whereas lower lid from the lower border of palpebral fissure to cheek. Normally, the upper lid covers the upper 1/6 or 2 millimeters of the cornea, whereas the lower lid is at the level of inferior limbus. And the vertical fissure height is about 10 to 11 millimeters. As age advances, this vertical fissure height decreases, become 8 to 10 millimeters in an elderly patient because of the development of aponeurotic ptosis. And the horizontal distance is about 30 to 31 millimeters. These are the positional anomalies of the lid. These include ptosis, that is drooping of the eyelid, ectropion, outward turning of the eyelid margin, or entropion, inward turning of the eyelid margin. Then these are the lid creases. The upper lid crease is formed by the fusion of LPS aponeurosis with the orbital septum. In Asian population, it is seen about 2 to 5 millimeters from the lid margin. Therefore, the orbital fat is more anterior and gives an appearance of fullness to the upper lid. Whereas in European population, this upper lid crease is around 10 to 12 millimeters from the lid margin. Then the malar and nasojugal creases limit the spread of blood and fluid from lid to cheek. Thus, this edema is confined to the periorbital area itself. The lid margin is divided into lacrimal and ciliary portion by the opening of lacrimal punctum. And this lacrimal portion is devoid of lashes. And the dense plexus of nerves and vessels are seen around these follicles, hair follicles of the ciliary portion, and is responsible for the tactile sensitivity of the lid. 100 to 150 cilia are seen in the upper lid, whereas 50 to 75 in the lower lid, and they are arranged in 2 to 3 rows with the glands of Z's and moles in the base of this hair follicle. Therefore, chance of lid infection is more in the upper lid. This is a case of Odiola externum characterized by pus pointing at the hair follicle hairline, and this has to be treated by epilation. Then gray line is the eyelid margin projection of orbicularis muscle known as rheolin muscle. It has very important role in the lid full thickness lid wound suturing. In wound suturing, first we have to align this gray line to get a better apposition of the wound. Then this is the structure of the eyelid. This from anterior to posterior, skin, subcutaneous tissue, orbicularis muscle, LPS muscle, molars muscle, tarsal plate with the meibomic gland, submuscular tissue, and the conjunctiva. These are the eyelashes. The skin of the eyelid is thinnest and highly mobile, and the skin laxity increases with age and which lead to dermatochalasis. Then subcutaneous tissue of the eyelid is loose areolar tissue devoid of fat, so easily distensible with the fluid and blood. So periorbital edema may be the first manifestation of nephrotic syndrome or angioneurotic edema. Then about the striated muscle, there are two striated muscles in the eyelid. They are orbicularis oculi and levator palpebris superioris. This orbicularis oculi muscle has three parts. They are orbital, preseptal, and pretarsal. The pretarsal portion is responsible for involuntary closure of the eyelid and normal drainage of the tears. And the orbital fibers are responsible for forced closure. And this orbicularis oculi muscle is supplied by seventh nerve. And the facial nerve palsy, there is a chance of impaired lid closure, which may lead to exposure of inferior cornea and conjunctiva and the exposure keratitis. To prevent exposure keratitis, we have to tape the lid in the case of seventh nerve palsy until the nerve recovers. The levator palpebris superioris is the retractor of the eyelid supplied by oculomotor nerve. The ligament known as Whitnall ligament is seen in this muscle, which separates the muscle into muscle belly above and the aponeurosis below. And this ligament has an important role in ptosis surgeries. And the aponeurosis is inserted into medial canthal tendon, posterior lacrimal crest, lateral canthal tendon, skin, tarsal plate, and conjunctiva. And the lateral aspect of this aponeurosis divides the lacrimal gland into orbital and palpebral portion. Disinsertion and dehiscence of this aponeurosis leads to development of ptosis. The non-striated muscles seen in the eyelid are Muller's muscles, and they are arising from the posterior aspect of the LPS tendon and is inserted into the tarsal plate. There is sympathetic innervation, and the peripheral arterial arcade is seen at the level of Muller's muscle in between this and the LPS. The sympathetic denervation of this muscle leads to Horner's syndrome, which is characterized by ptosis, meiosis, and anhidrosis. Then the submuscular connective tissue, they split the eyelid into anterior and posterior lamella. The nerves and vessels are seen in this layer, and local anesthetic agents are given to this space to get a better anesthesia of the eyelid. Then orbital septum arises from the superior and inferior orbital rim, which act as an anatomical barrier for spread of infection, hemorrhage, and edema. Therefore, preseptal cellitis, that is inflammation confined to the area anterior to the septum, and orbital cellitis, the inflammation is spread behind the orbital septum, and there is chance of spread to the intracranial areas in cavernous sinus, leads to cavernous sinus thrombosis. And the visibility of the orbital fat in lid injuries means the orbital septum is injured, and therefore there is a chance of injury to deep structures including the eyeball. About the tarsal plate, it is well developed in the upper lid compared to lower lid. The upper lid, the vertical height of tarsal plate is around 10 to 12 millimeters, whereas in the lower lid only 4 millimeters. And the horizontal length is 29 millimeters. Near the medial and lateral canthus, there is two tarsal plate joints, and the medial lateral canthal tendon is formed. It has a rigid attachment to the periosteum of orbital wall. The meibomian glands are arranged in this tarsal plate as vertical perpendicular to the lid margin. There are around 30 glands in the upper lid and 20 in the lower lid. The chronic inflammation of the meibomian gland is known as chalazion. The treatment for this is incision and drainage. When we are putting the incision from the conjunctiva side, we usually put vertical incisions to prevent injury to multiple meibomian glands. From skin side, usually horizontal incision to reduce the scar formation. The orbital fat, upper lid, the orbital fat is seen between the orbital septum anterior and LPS tendon posteriorly, whereas in lower lid, it is anterior to the capsula palpebral fascia. And this orbital fat has a thin, fibrous capsule. The upper lid, there are two discrete fat pads, nasal and central. Some orbital surgeries, lacrimal gland is mistakenly identified as orbital fat pad. The lower lid, there are three fat pads. They are nasal, central, and temporal. And the inferior oblique muscle run between the nasal and central fat pad. There's an importance in the inferior oblique surgeries. The canthal are the area of the junction between upper and lower lid. They join at an angle of 60 degrees with each other. In lateral canthus is in contact with the eyeball, whereas medial canthus is separated from the eyeball by the plica semilunaris and the caruncle. Normally, lateral canthus is at the level of or within 2 millimeters of the medial canthus. If the lateral canthus is more than 2 millimeters higher than the medial canthus, it gives an appearance of monkloid slant to the face. Whereas if the lateral canthus is at a lower level, it gives an appearance as an anti-monkloid slant to the face. The medial canthal tendon, the anterior part of it arises from the anterior lacrimal crest. Then it split into upper and lower part to enclose the lacrimal canaliculus. And it gives shape to the medial canthus and enclose the caruncle. And the posterior part is seen behind the lacrimal sac. During rhinostomy and dacrocystectomy, we cut this medial palpebral ligament from the anterior lacrimal crest to expose the lacrimal sac. Then angular artery and vein pass medial to the medial canthal tendon, artery being more medial to vein. The knowledge of this anatomy is very important to save this vessels during DCT and DCR while putting the skin incision. Fracture of the medial canthus leads to lateral displacement of the medial canthal tendon and appearance of telecanthus. And the medial canthal tendon is at the same position of cribriform plate. The conjunctiva has a keratinaceous squamous epithelium, and we can see the opening of accessory lacrimal glands like gland of Wolfram and gland of Cross-Endis palpebral conjunctiva. Then arterial supply. Upper eyelid is supplied by the branches from the internal carotid artery, whereas lower lid from the branches from the external carotid artery. These two vessels form a rich arterial plexus in these lids. Upper lid, there are 2 arterial arcades, whereas in lower lid, only 1 arterial arcade. This is the marginal arcade and this is the peripheral arcade. This rich collateralization between these two systems is responsible for rapid wound healing of the lid wounds and low incidence of infection following lid surgeries. Venous drainage. The pretarsal area is drained to angular vein and superficial temporal vein. The medial aspect to the angular vein, which in turn to the internal jugular vein, whereas lateral aspect to superficial temporal vein, external jugular vein. And the post-tarsal area through the ophthalmic vein to the cavernous sinus. Therefore, there is a chance of spread of infection from the lid to cavernous sinus and leads to cavernous sinus thrombosis. Lymphatics from the medial 1/3 of the upper lid and medial 2/3 of the lower lid drains to submandibular lymph nodes, which in turn anterior cervical lymph nodes. Lateral 2/3 of the upper lid and lateral 1/3 of the lower lid to preauricular lymph nodes and parotid nodes, which in turn to deep cervical nodes. About nerve supply, motor supply by oculomotor nerve and facial nerve. Sensory, ophthalmic division of trigeminal nerve supplies the upper lid and maxillary division to the lower lid through its multiple branches. And sympathetic supply to the Muller's muscles. Then glands, meibomian glands and Zeiss glands are the modified sebaceous glands seen in the eyelids, and Moll's glands is the modified sweat gland. These glands of Cross and Wolfram, the axillary lacrimal glands, are responsible for the basal secretion of tears, which keep the eye moist always. This is about the applied anatomy of eyelid. Thank you.